Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
What's up, y'all?
I'm Justin Burt, joined tonight by Dr. Chris the Chu Manchu. Our producers, Dr. Jess Kelly and Dr. Avram Morego. Jess, Avram, say hi. What's up?
What's up? What's going on?
Hey, guys.
Yo, full house tonight. It's a pool party here at the Cribsiders. Our
Avram's first pool party.
That's right, first pool party. Very exciting. It's a big deal. It's like a middle school milestone.
Solo cups.
Wonderful to have everyone. Had a lot of great learning this episode. Our guest tonight, Dr. Mercedes Blackstone, here to discuss water safety, drowning, and prevention. That's why we've already started the pool puns. But before we do more of that, I didn't say dive in. Chris, can you remind us about the show?
We're the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Mercedes Blackstone. Dr. Blackstone is an attending in the emergency department at the Children's Hospital of Philadelphia and a professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She teaches and writes about a variety of topics, including water safety. She enjoys working with a phenomenal team in the ED and strives to improve the delivery of safe, high-quality patient care. Dr. Blackstone teaches us about the ways to prevent drowning, how long to watch a patient who has drowned, and why we no longer use the term near drowning. Oh, so let's dive on in.
Perfect execution. 10 out of 10.
You had me treading water waiting for you.
Oh God.
Great work, team. Great puns. Welcome, Dr. Mercedes Blackstone, to the Cribsiders podcast. We're so excited to have you. Welcome.
Thank you so much for having me.
We're excited to have you. We're an informal group. Wanted to make sure, is it okay if we call you by your first name, Mercedes?
Of course.
Beautiful. Thank you. It's great to have you. We're excited to have you. We're excited to learn about you. And I know our listeners are very excited to meet you. Could you maybe introduce yourself, maybe give us a one-liner or something about things that you're interested in outside of medicine?
Sure. In addition to I'm a peds emergency medicine physician, mom of 2 daughters, giant dog breed enthusiast. I have a Newfoundland.
Nice.
In my spare time, I like running, New York Times word games, staying on top of the restaurant scene, things like that. You should take everything I say with a healthy dose of skepticism because I am a horrible swimmer.
Oh, interesting. Oh, this is upping the stakes of the episode. Are you a Connections player? Do you play Connections?
Yes.
That's one of the new New York Times teams. Yeah.
Every day.
That one's pretty tough. I was wordling for a while, but
What's
my streak is broken.
Connections.
Yeah.
Is it like a crossword puzzle?
It's the new Wordle.
No.
I need to figure it out.
It's
like
tricky.
Tricky.
Association. It takes less time than the spelling bee.
Aha.
Yeah, it's tricky. Yeah, spelling bee. My wife is very good at the spelling bee. She immediately sees the anagram or whatever. I see like cat, and that's as far as I get. Chris, you want to do a question?
Yeah, we should do some questions. Jess, you got anything?
Yeah, I'd love to hear. You are a phenomenal mentor. We all look up to you in the ER and hope to be like you one day. And what is the best piece of advice you would give to people as they're transitioning to new stages in their career?
At the phase you are starting as your journey as attending, I remember advice I got because emergency medicine, as you know, is all about efficiency and throughput. But when I was starting out, my mentor and now boss told me that just when everyone wants you to speed up, that's when you sometimes have to slow down. And I think of that all the time, especially at the end of a shift when everyone's like, quick, let's get out of here, get out of here. That when something gives you pause to like listen to that and pay attention to the patient in front of you. So I think that's one of the many pieces of advice that stuck with me.
I love that. I think that's such good advice.
Yeah, that's also really good advice to bring up if you're getting berated for going too slow. Be like, well, I wanted, it's me. That was my go-to in residency in the ED. Yeah, I'm just being thorough.
I'm practicing my type 2 thinking or whatever, which one.
That's right.
Oh, yeah.
Thinking slow.
Yeah, thinking slow.
My question is, if you were to recommend anything out of newly into pop culture, TV show, book, music, whatever, to our audience, what would you recommend?
I mean, there's so many good TV shows. I don't really have a book. I just think it's important that physicians read some book. I was an English major, and so I recommend reading some novel that people enjoy outside of medicine, because I feel like medicine can be very, very all-encompassing. Ironically, right now, the book I have next on my bedside table is Abraham Verghese, The Covenant of Water. But I'm always reading a book, but I don't know that I have like one amazing. He's a physician.
He's an off-sided physician writer. Fun fact, he's a family friend.
Really?
Yeah.
Am I saying his last name right?
Yeah, Verghese. Yeah, you got it. Abraham Verghese. Good guy. Hey, Dr. Verghese. Love the idea of just reading a book. Great call out for all physicians. And I forget if I did this, maybe I did this already as Picture of the Week, but I'm just going to keep talking about a book. I read Frankenstein for the first time recently.
Oh, yes.
Did I already do this one, Chris? Yeah. It's great. It's not like the traditional story of what we think Frankenstein is. It's actually this really beautiful commentary about what is humanity. Pick of the week for JB.
Some people may consider it the first sci-fi piece of work.
That's right. Cool. Well,
back to
I'm thinking about TV. I said the Bear is my favorite recent.
Oh, the Bear is dope.
Yeah, that's a good one.
Yeah.
Waiting for another one.
Yeah. The Bear is good.
Hey, Cribsiders listeners, let's talk some more about Freed. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. So here's the backstory. Gabby, a family medicine physician, and Erez, a computer engineer, came up with Freed, a solution that could help alleviate the daily burden of overworked clinicians everywhere. And for Erez, selfishly, it could mean that he would spend more time with Gabby, who was spending nights, weekends, and holidays updating medical documentation. So what does Freed do? Freed turns clinicians' daily workflow into accurate documentation instantly. There's no training time, no onboarding, no extra mental burden. All the magic happens in just a few clicks, so clinicians can spend less energy on charting and more time on what they do best. Today, more than 4,000 clinicians and their spouses have fallen in love with Freed. So Freed is this AI scribe that makes charting go away, doing your soap notes for you. It is HIPAA compliant, takes 30 seconds to learn, and costs only $99 per month. But you can try Freed for free right now by going to freed.ai. That's freed.ai. And listeners of Cribsiders can use code CRIB50 for $50 off their first month.
Speaking of the Bear and Frankenstein, Jess, let's dive into some content and talk about water safety and drowning.
Awesome. All right, we're going to start with our first case. So Wade is a 3-year-old healthy male. He presents to his general pediatrician office. His parents are taking him on a vacation to the beach and ask your recommendations on water safety. So to get started, what are the recommendations regarding water safety and drowning in children?
I would just emphasize to Wade's parents that the pool or the beach can be lots of fun, but that you do have to take water safety very seriously, since drowning is still a leading cause of death in children in the U.S., with about 1,000 children dying annually of drowning, and many, many more showing up in ERs like ours. And just that you might not see a lot of obvious struggle when children are in the process of drowning. They can just sort of go underwater. There's lots of terrifying videos online if you want to see examples of that. So they really just need very direct supervision near bodies of water. And so this parent needs to be focused on the child in the water, and they should really be within arm's length and not texting or chatting with their friends.
And what about like flotation devices, like the floaty devices? I mean, those seem like no-brainers, like great things, but are they evidence-based? Is that something that like you recommend children have, that they should be having the arm floaties, a life jacket?
Yeah, a lot of controversy about the floaties because some people worry it gives you the false sense. I would say they are an adjunct, but certainly not a replacement for that very, very direct supervision. And floaties are certainly not as good as a life jacket, which would definitely be recommended for all boating-related water things, water activities, especially for the older child. And then prevention-wise, and we're talking about a beach here, I think, but in the pool scenario, since lots of drownings happen in pools, we just mentioned that the other very successful thing that can prevent drowning is proper pool fencing.
Tell us about that.
It has to be a good fence, a fully enclosed fence around the whole pool. And self-latching, self-closing, not a fence that can be scalable or climbed. In lots of places, there's not good legislation to kind of maintain the fence, or only new houses have to have the right kind of fence. So good fencing can definitely has been shown to prevent drowning deaths, and is definitely superior to alarms or pool covers or things like that. And it should be a fence that's full perimeter, not attached to the house kind of thing.
That makes sense. One of the things that I've noticed just from friends that have kids now is some of the new swim lessons for babies. And so maybe before talking about swim lessons, there's this new phenomenon that I don't mean to ridicule, but it's literally, it seems like just throwing a baby in the water and trying to see if they'll like flip over. Seeing video of this is terrifying, but it's like a trend that, people are really selling. Is this an evidence-based intervention, or, is this something that parents can do to try to help teach their baby to naturally flip over so they don't drown?
Or do they look like the cover from the Nirvana album?
Great reference, Chris.
Yes.
Yeah.
I know. Videos everywhere of the babies just going in the water. Yeah. Swim lessons used to be controversial. The AAP used to not recommend anyone taking swim lessons until after age 4, because they felt like they couldn't handle it developmentally, and because they didn't want, again, parents to have this false sense of security, kind of like the floaties. But after some studies, they've kind of relaxed that position and recommended them anytime after age 1. I still don't think there's any evidence or a guideline to suggest the newborn baby water nirvana situation.
Got it.
I feel like a bad pediatrician because I took my 6-month-old to swim lessons.
Well, just non-evidence-based.
I think that's okay to explore the water. You were right there with him. As long as you don't set him free on his own now. And there is evidence that swim lessons help for sure. Experienced swimmers drown less, but knowing how to swim certainly doesn't mean you're in the clear, especially as you get older. Like we see in adolescents, they'll overestimate their good swimming ability and sometimes take risks that maybe they shouldn't.
Are there any specific things we need to know when we're recommending kids do get swim lessons, or parents come to us that they want to take their kids to swim lessons? Is the YMCA okay? Is the dude with their backyard pool okay? Like what constitutes swim lessons? Is there any type of special guidelines that these swim lesson places have to adhere to? I'm sorry, that's a bad question.
No, I'm just I don't know. I don't know of specific guidelines. I would probably not go with the guy in the pool, but
Steve.
But I think
Steve's a good guy.
But I think we might talk about the disparities that we see in access to swim lessons, and so I think any lessons, and I brought our kids to the local YMCA that are better than no lessons, and just understanding that a few lessons are not the same as proficiency. So a lot of pools will have a test, a deep water test that the kids have to do before they can be without an adult standing right by them.
And maybe before we get into a little bit of the demographics, this might be a terrible question that we get rid of, but is there a good understanding of like the mechanisms of drowning, of how people drown, as far as is it, often like slipping and hitting their head and going unconscious? Is it, having a seizure in the water? Is it not being able to swim? Is it, strong undercurrents? I'm sure there's a component of all of the above, but is there a common presentation of like a history of drowning or near drowning events, of something that is like the often cause, like whether it's beach versus pool or age or other external factor?
For sure, we'll see kind of bimodal distribution of drowning, and with the youngest babies drowning in bathtubs or even being victims of child abuse. And then toddlers are probably at the greatest risk, like age 1 to 5 has the highest risk of drowning. And those are often in small bodies of water and pools. And then more of those undertow and overestimation factors and risk-taking and alcohol in the teen population. What was the other thing you asked me? What was the other thing you asked?
That was a big thing, was, the population, the age, and the presentation. That makes a lot of sense. I was
going to say, to your seizure question.
Yeah.
I think we worry about certain medical conditions and drowning for sure. Seizures do put you at increased risk of a drowning event, and rare, channelopathies, lung QT type 1 and other channelopathies. But certainly, I think most commonly, it's the toddler that's just kind of slipping underwater that people aren't recognizing is struggling. And they often don't generate a lot of force in that struggle. And, they're just kind of getting lower and lower until they're underwater.
Maybe while we're talking a little bit about the demographics and the causes of drowning, are there other specific populations that are at increased risk of drowning? Like, are there racial disparities or socioeconomic disparities in populations that are presenting with drowning or near drowning events?
Yes, and yes, all of the above. So we talked about the age, and then being male is a much higher risk of drowning, pretty much at all ages after age 1. Boys drown much more, and this is really pronounced in the teen years when there may be some judgments and some risk-taking behaviors. And then just exposure, so there's increased risk with increased access to bodies of water. So the southern states have more, living in a southern state gives you a higher risk of drowning, or seasonal factors. If you live somewhere where it's often hot, or there's more drownings on weekends and in the summer. But then for sure there are increased risk with children of lower socioeconomic status who may not have been exposed to the water safety that we talked about or to swim lessons. And there are definitely studies showing increased risk in African American children.
And is there an understanding of why those societal risk factors increase risk of drowning in Black and African American populations? Is it lack of access to swimming lessons? Is that something that's deemed, or is there good thoughts on kind of the social rationale for why there's such a racial disparity in drowning?
I think there are thoughts and still, more study needed. Overall, drowning deaths have declined in recent decades, but this disparity has persisted. And some of it is for sure related to socioeconomic status. So, for instance, Black children are more likely to drown in public pools, whereas white children are more likely to drown in residential pools. So you can see some socioeconomics there. But to your question, there is some research that Blacks report a more limited swimming ability than members of some other demographic groups, and that this has persisted over time. But some of the statistics in certain age groups are very stark. You can see on the CDC pages on drowning, Black children between 10 and 14 drown in swimming pools at rates almost 8 times higher than white children. So in certain pockets, it's really pronounced. And we definitely need more research to kind of understand the other reasons for these disparities so that we could kind of develop effective community-based programs.
I think a lot of our listeners, as pediatricians, probably feel like they're advocates for child health, and hearing this kind of makes us want to think, what are things that we could do? So is there anything we can do to help address these health disparities?
Yeah, so for all our academic listeners, I think one way is studying this more. So a lot of this data from the CDC is based on review of death certificates. So it's really hard to retrospectively understand the factors that may have contributed to the drowning event, since a lot of these families, weren't interviewed about the particulars of the event. And the other way is things like you're doing, like educating ourselves. So, discussing the importance of water safety with all of our patients in primary care and kind of every chance we get, especially patients we know to be at increased risk. I work in the ER, so I'm not that often talking about prevention, but with seizure patients, for instance, I always talk about drowning at discharge, or even patients I think could have had a seizure, that's definitely a vulnerable population.
Warmer, sunnier days are calling, Cribsiders listeners. Fuel up for them with Factor's no prep, no mess meals. The key to Factor is they have dietitian-approved meals that can be ready in just 2 minutes. No matter how busy you are in the clinic, hospital, or at home, Factor has delicious meals for you. Choose between 35 different meals and more than 60 add-ons every week between the different meal options such as Calorie Smart, Protein Plus, and Keto. So Cribsiders listeners, treat yourself to restaurant-quality meals that feature premium ingredients like filet mignon, shrimp, and blackened salmon by heading to factormeals.com/Cribsiders50 and use code Cribsiders50 to get 50% off your first box, plus 20% off your next month. That's code Cribsiders50 at factormeals.com/Cribsiders50 to get 50% off your first box plus 20% off your next month while your subscription is still active.
Jess, you want to go on to our next case?
Yeah, let's do it. A 4-year-old male presents to the emergency department by EMS after being found at the bottom of a pool for an estimated 1 to 2 minutes before being pulled out by a bystander. He was unresponsive and cyanotic, and bystanders initiated CPR. So when this patient presents to your emergency department, what would the initial steps be in managing this patient? What would you kind of prioritize or be worried about?
I'll just say that the most important step has kind of also already been done in this case, and which is the quality bystander CPR. And since almost all of the morbidity associated with drowning is from lack of oxygen, it's just incredibly important to initiate CPR immediately in the drowning victim who's having any inadequate respiratory effort or if you can't feel a pulse. And unlike in other scenarios where we talk about, compression only CPR, drowning victims usually have a primary respiratory insult and really need those rescue breaths. So the drowning victim needs to be removed from the bad, dangerous situation and get the usual management of kind of airway, breathing, circulation while someone's calling for help. And then once they're in front of me in the ER, it would be the same kind of ABC priorities, I think.
So one follow-up question to that is then if bystander CPR is so important and say you're a parent in more of a backyard pool setting, I think a lot of large community pools, they probably have a lifeguard that they employ. If you're in those types of settings, is that then something that you would recommend that at least one of the parents who are supervising the kids should have maybe some CPR training? Would that be a good idea?
Yeah, I think that would be a great idea. That lifeguards, official lifeguards are expected to be CPR certified. And some communities will designate kind of pool watchers or water watchers or a parent taking a turn. And the more people educated in CPR, the better. And having AEDs at all of these pools, not everyone in your backyard, but at public pools can also save lives since some of these children will go into arrhythmias, especially the ones with these rare, especially those who might be the rare child who has an underlying arrhythmia that we didn't know about causing a drowning event. These lifeguards could be the ones to encounter that. And so an AED and CPR come highly recommended.
Is there anything special they need to do, like dry off the chest before they deliver a shock?
Yes, great question. They do need to dry off the chest to get the pads to stick.
Sounds just bad. Electricity and water.
Yes. And they don't need to do the Heimlich, importantly. I think people think that kids swallow a lot of water when they drown, and they may have swallowed some water, but doing the Heimlich can just delay the getting oxygen to their lungs and to their brain. So you just want to start CPR and administer rescue breaths.
And maybe this is a silly question, but I think it's something I've never really thought about. I think of often with CPR, especially in adults, you might have had an event, a cardiac event, and you're kind of restarting the heart until you can bridge to an AED and shot them and get it restarted. With the rescue breath being such a core part, you've seen the movies, the rescue breath, and then suddenly the kid coughs up water and is now back to normal. Can we talk a little bit is the point of CPR presumably that the heart has stopped and you're just kind of restarting the heart to get everything going while the body deals with the water that has been inhaled into the lungs, or are the rescue breaths helping to push the water out? Is there like a unique pathophysiology of what CPR is doing in a kid that's taking on a lot of water?
I think the biggest problem in drowning is that when that water gets in the airway, you get pretty significant hypoxia very quickly. And so just rescue breath to restore oxygen to the brain is probably the most important thing. I agree. It's very different than the usual adult cardiac arrest. In most of pediatrics, the heart stops because the breathing stopped, so this is another example where it's a respiratory insult. And then if you're hypoxic for long enough, then you may go into a full arrest. Especially in cold water drownings, the pulse can be very hard to feel, even if they may have a pulse. They just may be very bradycardic. So once again, focusing on breathing first, and then certainly if you don't feel the pulse, starting compressions.
So I'm sure this applies when they come into the ED, but maybe even when EMS is on the field. We're talking about hypoxia as being one of the major things. What are things you're doing to kind of assess the patient in that ABC? I mean, it sounds like the biggest concern is looking for hypoxia, maybe some disorientation. Are we immediately applying an oxygen mask? Are there other things that you're kind of looking for when you do your initial assessment of a patient who just had a near drowning or drowning event?
Good save, since we don't use the near drowning anymore, even though it's really hard not to use that terminology.
We don't use near drowning anymore?
I didn't know that. I didn't know that.
I didn't know. Yeah. What do we call it? We don't call near drowning. What do we call them now?
All these terms are confusing, like secondary drowning and near drowning and
near drowning used to be a Nazi,
drowning. I think. And so now it's just drowning, and drowning does not imply outcome. So you can have drowning with intact neurologic survival, or drowning with morbidity, or drowning with death. But it's very hard not to use near drowning.
Okay.
But I'll often use submersion injury for the something happened.
Yeah.
But especially for trying to promote research in the area of drowning, the World Congress on Drowning and the experts kind of suggested abandoning all these confusing terms.
Wow.
Because secondary drowning was another one that was like maybe secondary to something like a seizure, or maybe implied that they died later as a cause from the drowning.
That's a great pearl. And so for drowning events, we're not,
yes,
for, for drowning events, general assessment of things that you're looking for. Yeah.
Yeah, I think when they first come in, I mean, this patient that Jess presented sounds pretty sick, and so we'd probably be in the resuscitation bay. But for anyone with a drowning event, we would be very quickly, getting them on the monitor, getting vital signs, doing an ABC assessment, and importantly, D as well, and E, checking for their neurologic status and disability and exposure, getting wet clothes off, rewarming, and anything that's necessary there.
And how do you decide? So this patient came in, they're pulseless, you're providing rescue breaths. When do you say, I need to intubate this patient, or do you feel like, are there any good indications for that?
Yeah, it sounds like if this patient is still pulseless and we're providing rescue breaths, then they are likely going to be intubated. For the less clear patient who is having hypoxemia and some respiratory distress but is breathing on their own, I think you can certainly kind of use our usual indications of if you're not able to adequately oxygenate or ventilate them, or if you feel like their GCS is so low that they don't have intact airway reflexes. But many of these patients who, not this one, but the ones who have had some drowning event, submersion event, and, maybe at the scene were briefly unarousable, but then great bystander CPR got them back, or EMS. And now they're coming in just some respiratory compromise. Many of them we might be able to support with kind of usual adjuncts, with a little bit. Bronchospasm is very common in drowning, so many of them might just need beta agonist or some high flow or non-invasive ventilation. And a lot of patients who had some lung injury, but not to the degree of, still coming in a full resuscitation, we may be able to just support with other respiratory adjuncts.
And so let's say we have a patient like that who maybe didn't have CPR, but is coughing very heavily, is having a tough time, maybe had some shortness of breath, is having trouble breathing, needs a little bit of oxygen, but O2 is looking okay after a little bit of nasal cannula or something. Is the event over and now the patient can go home because they're kind of breathing on their own? We gave them some albuterol. Is it the event is done, or are there sequelae and complications that can occur over time?
Yeah, the event is not done, and so that patient is still scary because they may progress. So I think that's somebody we're going to watch very closely and admit to the hospital, since they may develop ongoing, this cascade of water having had contact with the lower airway and the lungs can cause surfactant washout and VQ mismatch and shunting and kind of an ARDS picture. And so, there's a whole spectrum of that, from the kid who, just aspirates a tiny amount of water to the more significant drowning victim. But anything where they're having some degree of respiratory compromise, we're going to want to watch very closely for evolution of pulmonary edema or worsening respiratory impairment.
And to kind of prevent some of those things, like, are you ever considering steroids or prophylactic antibiotics? Is there anything that you do to try to prevent those complications from occurring?
Unfortunately, none of those things have been shown to help. So we don't give prophylactic antibiotics. even in the Schuylkill River where we live, which is a pretty gross body of water. Unless there was a very specific drowning scenario. They fell into something that was very contaminated. Prophylactic antibiotics aren't usually recommended, but if they did develop infiltrates on X-ray and a pneumonia picture, then you would want to think about coverage a little more broadly than you might for a regular community-acquired pneumonia. You would want to cover organisms that live in the water, Pseudomonas, Aeromonas, things like that. It feels strange not to give somebody so sick prophylactic antibiotics, but they just haven't been shown to really benefit drowning victims. And the same with steroids. We give steroids at the drop of a hat for asthma, but hasn't really been shown to help either for these patients. There's been some case reports and small things looking at surfactant or nitric. And so I don't think we have enough evidence yet for really any of those measures, but there may be some role in the future.
And Jess, I think you had a great question that I'm not sure the justification for, so I'm very excited because I think it's probably a real thing.
I think one thing I'm always curious about is I see someone come in from EMS and it's involving a swimming pool, and I always worry, was this a diving incident? And so are there specific scenarios where you'd say, oh, this patient needs to be in a sea collar, versus other scenarios where you might say, nah, this is a 4-year-old, he probably just slid in?
Yeah, great question, especially because we know once they come in the sea collar, it's very hard to throw away the sea collar. And so these drowning patients in the pediatric population that we're talking about really don't need to kind of empirically be put in a collar, except in those specific instances. So yes, if this was a car accident that landed in the water, that's a different story. Or,
sounds like the worst polytrauma to come in.
The teenage male that we talked about who might be doing stupid things and jumping off high things and diving, that's clearly somebody that we want to put in a collar. But a few studies have looked at this in drowning victims in particular, and really all the patients who had C-spine injuries had one of those concerning mechanisms, like an MVC or like a diving event. And the collar is not only not helpful, but it's often counterproductive because of our priority of really reversing that anoxic injury and good airway management, possibly needing intubation. The collar just often makes all of that more difficult. So it seems like a benign intervention, but actually is not recommended for the majority of pediatrics drownings because of how we talked about. Most of them are often just the toddler kind of slipping under. So the most common scenario is that child just found in the bathtub, found down, or found in the pool, and those patients should not be collared.
Super helpful. It's like the cascade of interventions with unnecessary consequences.
Yes. I guess I'll say one more thing, that at least in the ER, we usually have no idea what happened when the patient arrives, or the story's going to change 5 times. So sometimes the patient arrives prior to an adult or anyone who witnessed it. So of course, if you're unsure, it's perfectly reasonable to put the collar on until we know more and learn that there was definitely no diving incident or anything like that. But if you knew the circumstances, often it can be avoided.
And maybe, do we want to touch on a little bit more any other details about the pathophysiology behind drowning? Because it sounds like, obviously there's water going into the lungs, which is concerning. We talked about some of the hypoxia, but what's going on? Why is it taking a while for these complications to occur? What is kind of the pathophysiology behind drowning events?
Yeah, it's scary to even read about the pathophysiology. It just sounds horrible, but it's because you have this initial panic and then you lose the normal breathing pattern. Confusingly, you still have this reflex inspiratory effort. So you're still sometimes breathing in the water and taking on water that can lead to aspiration and laryngospasm. And the trachea and lungs just don't like water, even in pretty small amounts. And so the hypoxia starts pretty immediately as soon as you get water in. And if you did have some laryngospasm, as that abates and you aspirate more water into the lungs from water that you swallowed, you just kind of get this bad cascade of a drop in your PaO2 and a rise in your PaCO2 and acidosis that leads to the whole badness of surfactant washout and VQ mismatch and ultimately ARDS.
And so to go back to some of the monitoring, I mean, it sounds like we're not doing steroids, we're not doing antibiotics. A lot of it is just monitoring for either a pneumonia that we'll talk about, or to see if they go into an acute respiratory distress syndrome like picture that would need positive pressure ventilation and potentially intubation. Is that right? So we're basically monitoring to see if they need more mechanical ventilatory support.
Yes, I think that's right. And I think as, we've learned more about resuscitation, and our critical care colleagues have gotten amazing at kind of resuscitating the lungs and advanced ventilatory support, that they can often get a drowning victim through even a very severe respiratory event. And then we're often dealing more with the neurologic compromise from drowning.
So that was going to be my kind of follow-up, or what are the other complications? Talking about what are some of those neurological complications or other things that might be going on?
Yeah, I think, that final common pathway of the low oxygen and acidosis, that's bad for all the organs. So drowning can really lead to kind of multi-organ system failure like sepsis. But probably the biggest one, other than the lungs, is the brain. And the anoxic injury that leads to neurologic impairment is the other most serious outcome that we're dealing with.
Well, I was going to say time course. How long are we monitoring? Whether it's respiratory versus neurological, how long are we watching? When do we expect to see recovery or deterioration? And maybe not to do a double question, but in addition to the time and clearance, where do they need to be monitored? What level of care? Is this an ICU setting? If we're worried about ARDS and neurological, bad outcomes, like a neuro ICU, or is this something that the ED and floor can handle with a few hours of monitoring, and then if they're breathing, talking, they go home?
Yeah, I think it depends on the patient. Certainly, if they're worsening in the ED, I think that is, and needing non-invasive ventilation, clearly that patient's going to go to the ICU. But yeah, if they're, should I talk about disposition in general?
Yeah, I mean, we can get to it too, but yeah, I think whatever kind of made sense naturally. I think, the idea is, let's say we have a kid, let's say Wade is past the event, but now he's in front of us. He doesn't need immediate intubation, but he's not looking great. How do you monitor, I guess, the trend, the progression of where he needs to go and what he needs to receive or what needs to be monitored?
Yeah, I think if he's either getting worse in front of our eyes or having significant respiratory support, then that's going to be somebody that we would admit to the ICU for that, since we know that their lung disease could evolve. Similarly, if he's already neurologically compromised and has altered mental status, that's a patient who should go to the ICU for ongoing kind of neuroprotection and frequent neurologic checks. But there is a subset of drowning victims that might be perfectly safe for the floor, who, just are slightly tachypnic or have an ongoing cough that we want to keep a close eye on. And, if they're getting worse, maybe they would need transfer, but usually we would observe them for several hours in the ED first and kind of demonstrate relative stability, and they might be fine for an overnight observation.
Say, I have a follow-up to that. Say you had a patient come in and had a relatively minor event, and maybe they look like a rose. They're not tachypnic, they're not coughing. They honestly look great. Is there a certain time period you would watch them for and possibly consider sending them home, or does an event like this automatically buy you an admission?
Yeah, there are definitely patients we can send home. And I think there's more ongoing research in that to try to narrow that down or find, kind of a scoring system of who can safely be sent home. But for that patient you're describing who maybe had something that was a little concerning but now is looking really well, we would usually watch them for about 6 to 8 hours after their event, after their initial submersion. And at the end of that time, if their vitals are completely fine and they're not having any increased work of breathing and their mentation is perfectly normal and their oxygen sat is normal, they are certainly candidates for discharge. Somewhat arbitrary time frame comes from a few smaller pediatric studies that really showed that anything bad that was going to happen happened within those first 6 or 7 hours, or you had at least a sign that they were getting worse. And if they're still stable after all that time and they didn't have a significant resuscitation at the scene, then they are certainly candidates for discharge with good, return precautions.
And would you get a chest x-ray on them on their way out the door just to really make sure?
Yeah, it's really hard to do nothing. I think I probably would, and I would feel more reassured if that x-ray looked normal. However, there is some conflicting guidance that, the x-rays, because we've all gotten many x-rays with a little bit of something on it in a very well child, x-ray we were getting for some other reason. And so there's been some suggestion that, you could have an abnormal x-ray in a completely asymptomatic child or a normal x-ray in a patient who does have some mild symptoms. So I think it's one more piece. And clearly if it was impressive and looked much worse than the patient, then that might be someone we would say, oh, maybe they are developing some early signs of pulmonary edema. Maybe we should watch them longer. So I wouldn't hang my hat on it, but I think it isn't one more helpful piece of information.
Maybe we'll talk about diagnostic imaging, because I think that'd be good. And I'm curious to hear about labs. But for the x-rays, this is maybe selection bias from some of the cases I remember of drowning patients. Some of the x-rays look pretty gnarly, right? I mean, you can get pretty significant findings that are concerning, presumably from pulmonary edema and inflammation and kind of that preemptive ARD state. Is that kind of what's going on?
Yes. And I think, this is what the media sensation of the dry drowning, or the kids who were in the pool earlier in the day and then had some terrifying event at home. That's probably what was going on, is that they, should have sought care, didn't seek care after an initial submersion injury, and were kind of slowly developing signs of pulmonary edema. But as long as they are watched for some period after, it shouldn't be, days delayed, as has sometimes been suggested in the lay press.
We love ordering tests and love doing diagnostic things, so it's just fun.
That's the med part of your med piece.
Yeah, should we CAT scan or MRI these kids? Yeah. Is there labs that we should get? Should we be checking this kid's iron level? No, should we be doing any other lab work while in their ED? Is a CRP predictive of anything? Is there anything we should be looking for other than just radiating their lungs?
This is another, I think we have the bin of the well patient that we're hoping to send home if they stay well over that observation period, and they might get the x-ray, and that patient we might do no lab tests. I'm not sure anything is going to be super helpful. Studies have shown that we don't get electrolyte shifts from routine drowning events unless you live in the Dead Sea. So you don't need to just routinely, you don't need to check electrolytes just because they had a freshwater drowning or a saltwater drowning. So those patients might not get any labs. Then this Wade, our sick patient who had CPR and resuscitation, he's going to get all the labs. And yeah, that is a patient that I think we would get. We'd be looking for those kind of end organ signs. So that patient, we would want to see electrolytes, a creatinine and LFTs and even coags, because they can go into coagulopathies, and an EKG and a blood gas would be helpful in our sicker patient populations. And then, in the patients who may have had a medical cause, AED levels, and remembering tox screens in our more adolescent patients.
That sounds great. Are there any things that are maybe imaging or lab work that are other prognostic factors of what might be good or bad? Like if everyone they have stone cold normal labs, they have a normal X-ray, a normal gas, can we say that those are all pretty encouraging?
Yes. Yeah, I think we can. There's been a lot of attempts to predict who will do well and who won't, because it could be very hard to tell initially in that first resuscitation, and scoring systems kind of going back even to the 70s. But most of them are pretty intuitive. So really the better outcomes are with, shorter submersion time, shorter time to CPR, and EMS, and short pre-hospital time, and then looking better on arrival. So, more concerning to have a low GCS on arrival, more concerning to have a really severely altered blood gas. That being said, because of many case reports of drownings in very cold water locations, where patients have had good neurologically intact survival despite all of those parameters looking dismal initially, we'll often recommend kind of a prolonged resuscitation in a very cold water drowning victim until you can rewarm them and get a better sense of their prognosis.
And maybe while talking about prognosis, we've talked a little bit about neurological outcomes. Can you talk about some of the long-term neurological outcomes? Are most kids doing okay? Are they recovering relatively quickly? Are there predictors of long-term neurological outcomes? What are some? I mean, is it just, I presume it's hypoxic brain injury, but can you talk a little bit about long-term neurological outcomes?
Yeah, I think unfortunately that's what we see a lot of with a significant drowning event is a dismal neurologic prognosis. If you have, a low GCS and continue to after lifting sedation and a CT that shows signs of anoxic brain injury. And so it's really time without oxygen. And there's been lots of attempts to see, are there any therapies that kind of reverse the neurologic insult? And unfortunately, it doesn't seem like that insult is particularly reversible. So the neurologic management is really kind of preventing secondary injury, sort of like stroke management or something, kind of managing the drowning victim with euglycemia and preventing fever and preventing anything that increases metabolic demand and preventing increasing their ICP as you support the lung and brain recovery.
Regarding the drowning in saltwater versus freshwater versus sewer water versus pool, does that change the management at all?
Sewer water, we might prophylax.
It's hard not to do it there.
That's a noted exception to the no antibiotics rule. But other than that, no. We used to worry a lot about shifts in electrolytes, but it seems that you need to aspirate just huge amounts of water for that to occur. And because of the pathophys, and because of how quickly you kind of breathing with anoxic injury and have laryngospasm, children generally don't aspirate anywhere near the volumes that would be required to cause electrolyte shifts. So we don't really care where it occurred. I guess we do care about the temperature of the water. Where we live, we basically are never dealing with the really, really cold water drownings, like less than 5 degrees centigrade, that would be required to kind of trigger the mammalian diving reflex and result in these crazy cases where patients were pulseless for a very, very long time and then come back to life with intact neurologic survival. So they don't really apply to the patient who's cold because they've been down a long time. It has to be kind of slipping under the ice. Those are patients that you might resuscitate for a very, very long time because hopefully they triggered that mammalian diving reflex and could have some neuroprotection.
That is something I had never heard of before and sounds so impressive. Is there any mortality benefit to drowning in fresh versus salt water, or is it pretty the same?
I don't think so. I think the only mortality benefit is the very cold. If you can be rescued from very cold water that may have triggered you to shunt blood to your vital organs, to your brain and heart, then there are some patients with good prognosis, though some studies have also challenged that and still shown that if you're not having ROSC in the first 30 minutes or so of resuscitation, that the prognosis is still poor.
And are there any resources that you give families on water safety, whether community resources or websites or other things that...
I don't have a good answer to this because I don't give it's like a primary care.
The pre-printed ABS is great. Yeah.
All right.
I mean, I look at the CDC website and I think they have some resources, but I don't give out. But I hope my primary care colleagues do.
So Mercedes, we really, really appreciate the time you spent with us today. As we sort of get close to signing off, I was just wondering whether you could give your main take-home points to our listeners.
I think some of the take-home points are that depending where you live, you may not see it that often, but that drowning is still a leading cause of pediatric morbidity and mortality, so something really worth learning about and trying to prevent in our patients. And then that rapid rescue and bystander CPR is essential for survival and good neurologic outcome for these patients. That the goal of our care, both pre-hospital and in-hospital, is to reverse hypoxemia quickly, and that there are some select patients who don't require admission. And lastly, just that we can't emphasize prevention enough.
Excellent. Thank you so much.
Anything you'd like to plug? This has been wonderful. Mercedes, thank you so much for your time, your expertise, and for teaching us all about drowning and what used to be called near drowning and secondary drowning, but is now called drowning. And not just
don't call it those things anymore.
Diagnosis and prevention. This has been great. I've learned a ton. I think it's going to be really helpful for patients in the ED, in the hospital, for med students, for attendings. This has been great. So thank you so much for coming on the show.
Thanks so much for having me.
The number you have dialed has been changed. The new number is...
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly knowledge food formula feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, Google Play, or any of your favorite podcast players, or you can email us at thecribsiders@gmail.com. A special thanks to our producers for this episode, Dr. Jess Kelly and Dr. Avram Rego, our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Jess Kelly.
I've been Avram Rego.
And this has been Chris the Chew Man Chew. And as a bonus for everyone who made it to the end, is another poem written by AI. In depths where shadows weave and waters chill, a silent specter in the twilight spills. Children who in innocent play do part, they find themselves caught in Neptune's dark heart. From gentle waves to peril unfurls, where laughter turns to fear as water swirls. The guardians vigilant by every shore must watch, must save from death's quiet lure. Beneath the surface where one's lost sleep, swift intervention a promise to keep. Rescue breaths to steal back from the grave. In those desperate moments, fiercely brave. Water, once a playground, soft and mild, now a siren calling to the child. Yet knowledge is the beacon we must teach, to stay within the safety that shores can reach. In pools of sorrow where tears are made, each guardian learns the weight of their trade. The hope, a whisper, to save and mend, for every life brought back from the end. See you guys.